Hello friends, we're going to talk about laryngomalacia in this presentation. So this is one of the airway malformations, and really laryngomalacia is a true malformation. Some of these other things like subglottic stenosis and tracheomalacia, they can be acquired, and so in that case it's really not an airway malformation, but just a structural issue. I don't want you to come away thinking that all of these things, what laryngomalacia is, but subglottic stenosis and tracheomalacia, they can be indeed acquired. Okay, so this is a disease of the supraglottic structures, so above the vocal cords, and therefore this is going to be associated with an inspiratory stridor, adventitious lung sounds during the inspiratory phase. We'll see that subglottic stenosis is associated with a biphasic stridor, so you'll hear it usually both during inspiration and expiration, and tracheomalacia tends to be more in the expiratory phase. We'll go over the relevant anatomy that you'll want to be aware of, especially when if you're doing a fiber optic bronchoscopy, you'll want to know what structures are where. So I've got some pictures for that. We'll do an overview, then we'll talk about how this tends to present, how you can work this up, and then how we go about managing laryngomalacia. So this is the airway. This is a left oblique view. You can see here I've removed the mandible and also various structures, including the cervical spine. So this is the hyoid bone. This is an important structure, landmark structure. Usually you can palpate this in a child. Here's the thyroid cartilage and the cricoid cartilage. Remember, at the cricoid cartilage, this is the narrowest point of the airway. So laryngomalacia is going to be above the vocal cords, so it tends to be behind the thyroid cartilage, the hyoid bone area. So here's an anterior view. Various structures are removed here. You can see the beginning of the laryngopharynx. Here's your hyoid bone, the thyroid cartilage, cricoid cartilage. There's a few ligaments here, the thyroid hyoid ligament, which connects the thyroid cartilage to the hyoid bone, and the cricothyroid ligament. This is the area where you do your tracheoscopy. And this is between the thyroid cartilage and the cricoid cartilage, and then at that point you have your cartilaginous rings of the trachea. So just dissecting this a little more, visualizing the laryngopharynx. So we're looking at this as if you were looking through the patient's mouth. So here's the uvula, the tonsillar structures I've dissected out, and then here's the oropharynx. The epiglottis makes up the anterior portion of the pharynx, and then it sits behind the cartilaginous structures. So let's get a better view of this here. Okay, so this is looking downwards. Here's your esophagus here, and then the trachea. So we're going down into the trachea here. These are your vocal cords, and then downwards, and then here's your bifurcation. So this is a superior view. The larynx has been faded out. All right. So this is anterior down here and posterior. This is sort of the view you're going to have when you're doing a laryngoscopy. All right. Okay, so this is your esophagus here. This is just visualizing the pharynx. So this is sort of laryngopharynx area. Here's your epiglottis, and then this is where the vocal cords are. This area here that sort of connects the epiglottis to the laryngopharyngeal area is called the aryepiglottic folds. Just taking its name from the arytenoid cartilages, which are here. You can't see the cartilage, you just see overlying mucosa here, and then the epiglottis, which it connects. All right. Oh, I should tell you here. So when you're swallowing, the epiglottis, what it does is it flexes backwards, and it covers up the trachea. So you probably know that, but you can see how this is just sort of a flap that comes down. So when you're swallowing, everything gets redirected into the esophagus. Okay, now I've established that. Okay, so this is what a normal laryngoscopy looks like. You can see how it's similar to this shape here. So what we're visualizing in this laryngoscopy is this area. We don't see the esophagus. So you can see it looks pretty similar. This is your epiglottis. This is the way it should look. It's sort of just this flappy structure. And then here's your vocal folds down here, but connecting the epiglottis to your arytenoid cartilages, which are just these tiny little bulges on the posterior end, is the aryepiglottic folds. folds. So again, here's another view. You can see your arytenoid cartilages are a little bit more prominent here. Here's the area epiglottic folds, connecting the epiglottis to the arytenoids, and then here's your vocal cords. So this is all normal here. Laryngomalacia is defined as a collapse of supraglottic structures during inspiration, and that's going to be what you notice when you do fiber optic bronchoscopy to diagnose it, and that's the best way to diagnose laryngomalacia. It results in intermittent airflow impedance and inspiratory stridor. During inspiration, the structures will tend to collapse. Because it collapses, it causes resistance and subsequently turbulence, and that causes stridor. Laryngomalacia is not a structural disease. It's not due to a defect in cartilage. That used to be the theory. That's been proven wrong, though. What this likely is caused from is a neuromuscular issue where there's immaturity or improper integration of the peripheral nerves. Also can affect the brainstem nuclei and other pathways that are responsible for swallowing and maintaining airway patency. So this is likely neuromuscular in origin. Nevertheless, there is probably no genetic correlation. It doesn't tend to happen in families, so it tends to just be sporadic. Most common cause of stridor in neonates and infants. So this is a big one. So if you have a case of stridor in an infant, this should be number 1 on your differential. This is a brand new baby. And typically this will present shortly after birth, but it may take a little while. So it tends to present between birth and a few weeks of age, and it also tends to worsen over the first few months of life. The vast majority of cases are self-limited and only require observation, and they will resolve by 2 years of age as the airway grows. So when you're born, your airways are really small, and any collapse is going to result in a significant resistance. So remember, back to Poiseuille's law, your resistance is inversely proportional to your radius. So as that radius grows, as the child grows, even though you may have some collapse still of the laryngeal structures, it's not going to cause as significant resistance and turbulence as earlier during life when the airway is smaller. So the presentation is inspiratory stridor between birth and several weeks of age. You can have feeding difficulties as well. You tend to have feeding difficulties. The stridor is classically worsened by agitation, crying, feeding, and supine positioning. Also, if there's a concomitant respiratory tract infection, that can worsen things as well. And why? It makes perfect sense. A respiratory tract infection is going to cause some edema, some inflammation of the airway, and that's just going to make things all the worse because you're already dealing with a collapsed airway or a collapsible airway. And so if you already have edema, that already narrow radius of the airway is going to be made even more narrow. The differential diagnosis includes other causes of afebrile stridor, so note that this is afebrile stridor, not febrile stridor, so this is not including things like a peritonsillar abscess or a retropharyngeal abscess or epiglottitis or bacterial tracheitis. Those are all febrile stridors. So subglottic stenosis, this tends to be a biphasic stridor. It also is, of course, afebrile because it's a structural issue, but this tends to be biphasic. Vocal cord paralysis, this can be difficult, but in these cases there tends to be a raspy voice. It's also associated with neural tube defects, Chiari malformations, and post-operative. Particularly think about if there was any kind of heart surgery. You could nick that recurrent laryngeal nerve. That can cause vocal cord paralysis, and that can also then lead to stridor. Foreign body aspiration. So this is going to be a little bit easier to differentiate because this will be a child that didn't have any symptoms, suddenly, boom, stridor. And so this will be a sudden onset. Tracheomalacia tends to be more of an expiratory stridor or a wheeze. And then croup, again, this would be something that's more acquired, low-grade fever, barking cough. Your workup is going to mostly be clinical. So this is going to be somewhat easy to diagnose because this is, like I said, the #1 cause of stridor in infancy. And typically these cases will come on very early in life, and that makes it a little bit easier to differentiate out, especially if you don't have the precipitating causes for vocal cord paralysis, and the stridor tends to be inspiratory only in nature. So a presumptive diagnosis can be made with classical symptoms of inspiratory stridor worsened by the typical aggravating factors. You can get an X-ray. That often will help you differentiate this out from subglottic stenosis, but that's not necessary. Ultimately, no matter what, you have to get laryngoscopy. So that's your way to definitively diagnose laryngomalacia, and you'll be able to differentiate this very easily from subglottic stenosis and tracheomalacia just based on your visuals. So in 88% of cases, you can make the definitive diagnosis. This is the most accurate test. And in many cases, this can be performed on an unsedated child, either in the ED or in the clinic. So this is something that you should do if you have suspicion for laryngomalacia. So when you're looking at, with the laryngoscope, what you're looking for is, as already mentioned, an inspiratory supraglottic collapse during inspiration, of course. You'll also see poor vocal cord visualization because you have that collapse. And then the epiglottis is characteristically omega-shaped. So normally the epiglottis kind of has this flat shape to it, but with laryngomalacia, it tends to be more omega-shaped, kind of curly. These are all indicative of laryngomalacia. Other things that you can see include a retroflexed esophagus, epiglottis, retroflexed epiglottis. You can see postglottal edema, shortened area epiglottic folds, and so forth. Okay, so this is your classic omega-shaped epiglottis. So I turned this upside down because this picture is, I wanted to make these from the same perspective. So this is anterior up here, posterior down here. You can see that normally the epiglottis has this sort of straight flap-like shape. This here, you've got this sort of curving where the left and right sides are kind of coming together here. And all we're visualizing here is pretty much the epiglottis. And then here's your area epiglottic folds down here, but you can see this very classic omega shape. So again here, you see this is inspiratory. This is an inspiratory phase here, so you see poor visualization of the folds. You can see one of the vocal cords down here, and then your omega-shaped esophagus. Also, you can see a little bit of shortening of the area epiglottic folds here. This is after surgical correction. We'll talk about that in a little bit. So again here, you can see the vocal cords a little bit, but again, you have this omega-shaped epiglottis, omega-shaped epiglottis. So that's, I don't think you're going to get a question on the test that's going to ask you to look at a picture from the laryngoscope. You should know that laryngoscopy is the best way to diagnose laryngomalacia. But if you do get a question and they do show you a picture, look for this omega-shaped epiglottis. I don't know why I keep saying that. Omega-shaped epiglottis. All right. It's late. I'm recording this at about 1 in the morning here, so. All right, so here is a severity scale. This is useful because this will help you decide whether or not you want to go forward with surgery. And in most cases, like I said, this only requires careful observation, follow-up, and it is, in most cases, self-limited. However, based on the severity of symptoms, you may want to you'll probably do a referral to ENT in all cases, but you want to know if the patient may need surgery, just so you can make the parents aware and stuff like that. So this is a severity scale, and you look at both respiratory symptoms and feeding symptoms. Why respiratory symptoms? Well, because if you have cyanosis and apnea, that's a big deal. And also the feeding symptoms, because even if the respiratory symptoms aren't that bad, but the child's having difficulty feeding, that can lead to failure to thrive. So mild would be just your inspiratory stridor, which is characteristic of laryngomalacia, and a normal average resting oxygenation of 98 to 100%. Feeding symptoms, usually in laryngomalacia you will have some. In mild cases, it'll just be an occasional cough or regurgitation. In moderate cases, you'll have your inspiratory stridor, of course. Average resting saturation may be a little bit lower, but the feeding symptoms are usually a little bit worse in the moderate cases, so you can have frequent regurgitation or other issues. In severe laryngomalacia, you will have, of course, inspiratory stridor that can be complicated with cyanosis or apnea, and the resting oxygenation is going to be a lot lower. And then with the feeding, you can have aspiration, and because there's so much feeding issues with regurgitation and all that stuff, you can have failure to thrive. And also keep in mind that if the respiratory problems are worse, that's going to require more work to get oxygen in, and that's going to result in more calorie expenditure too. So that's another thing that will cause failure to thrive. So you don't need to know this scale for the test by any means. Don't worry about committing this to memory. Just know that there is varying degrees of laryngomalacia, and these more severe symptoms will make you think that perhaps we need to intervene surgically. So the majority of cases will require only conservative management. You'll do regular follow-up. You can also do symptomatic care. So thicken the formula, feed the child upright, and then if there is any reflux present, you can treat that. Make sure that you're plotting this child on a growth chart, keeping very, very, very close monitoring of the symptoms and of possible failure to thrive. If there is failure to thrive, then you may want to go ahead with surgery, especially if the child's really young still. Severe cases are typically managed surgically, and the therapy done, the surgery that's done, is called a supraglotoplasty. And supraglotoplasty just means correction of the structure superior to the vocal cords. Other possible indications for surgery just include things that indicate that you have respiratory distress, or that you have complications of respiratory distress, or things that could put you at risk for respiratory distress. So stridor and respiratory distress obviously can be an indication. Dyspnea with significant retractions, which is really the definition of respiratory distress. Pectus excavatum. So if there is a pectus excavatum, remember that's just a deformity of the sternum. If it's this is the inward dent as opposed to carinatum, which is outward. So this is the with pectus excavatum. What that does is that reduces your maximal lung volume, and so that can already add on to the degree of respiratory distress that you can get. Other things include pulmonary hypertension, cor pulmonale, severe obstructive sleep apnea if that's present, then episodic cyanosis with feeding, recurrent aspiration pneumonia, and failure to thrive. So all these things may be indication for surgery. Not necessarily. None of these are absolute indicators. But if you have any of these things, you're definitely sending the patient off to an ENT for evaluation. Okay, so this is just some sort of ancillary information for laryngomalacia. In about half of patients, it's been reported they have what's called synchronous airway lesions, which can include other problems of the airway, including tracheomalacia, which is a cartilaginous issue of the structures of the trachea, subglottic stenosis, and vocal cord paralysis. So usually, if these are present, this can make the condition a little bit worse, and so that can be something that may precipitate the need for surgery as well, but not in all cases. Only about 4.7% will require further intervention. There's disagreement as to whether further workup is necessary once you diagnose laryngomalacia. So what that means is, we've diagnosed a patient with laryngomalacia. Do we want to investigate to see if they have any of these other things? It's disagreed. So don't worry about that for the test. Polysomnography may be indicated if there's nocturnal hypoxemia. So you have the patient in, you're observing them, and their saturation drops at night. You may want to do a polysomnogram to see if there's obstructive sleep apnea. At that point, they may go in for surgery. Echocardiography will be indicated in all patients that have congenital heart diseases. You want to do this before surgery, as well as to ascertain the degree to which the congenital heart disease is contributing to the hypoxemia as opposed to the laryngomalacia. So you have a child with a congenital heart disease. You don't necessarily do surgery on that. Like, for instance, if you have like a patent foraminovalle, you don't necessarily have to do surgery there. However, that can contribute to a hypoxemia if you already have the laryngomalacia on top of that. So you want to know the degree to which the congenital heart defect is contributing to the hypoxemia, because if it's the congenital heart disease that's causing most of the hypoxemia, then you don't necessarily need to do surgery on the laryngomalacia. But that really is going to be at the discretion of the pediatric surgeon. I don't expect that you're going to need to know that judgment call as to whether or not you're going to have to go forward with surgery. For the test and for your purposes as a hospitalist or a general pediatrician, what you need to know is that laryngomalacia is typically treated with supportively, close monitoring, and referral to ENT. In a minority of cases, it will require surgery. ENT in a